All right, we are live, and it's a pleasure to come at you here from a fall day here in the with the beautiful colors here in Minnesota, where the leaves have pretty much fallen off the trees. But it's great to be with you tonight, and I just want to thank you for joining us tonight on our Facebook Live with Keith RN. We have this every month, and the purpose of this live stream is just to give educators free access to innovative content that's going to equip you to better prepare your students for practice, and as well as giving other educators a platform and sharing their innovative strategies. And so I'm excited to have a guest, Rachael Lattanzio from York College in Pennsylvania. He'll be the conversation about beyond clinical busy work, a better way to build clinical judgment. And what I want to share with you is that this conversation, we're going to be kind of highlighting a best practice strategy that was published in the Journal of Nursing Education back in 2021, Nancy Eisenman, and she had an article titled An Innovative Clinical Concept Map to Promote Clinical Judgment in Nursing Students. And with this article, it just triggered me because she talked about Tanners, how to operationalize those clinical reasoning steps of noticing, interpreting, responding, reflecting into a concise concept map that emphasizes clinical judgment. And so we're going to talk about a tool that I developed and that our guest has used in her clinical setting, and just kind of talk about some practical ways that we can really operationalize Tanner's clinical judgment model and what that looks like to real world practice. And so I just want you to know that these live streams that we do every month, they live on our YouTube channel, Think Like a Nurse. And I just want to share the link to that. If you're not a subscriber to our channel, we've got over 100 videos, content for educators, prior Facebook Lives. Last month, we talked about eliminating busy work and in nursing education, and how we can do that more effectively, and kind of just, again, not just assign content, but really avoid the busy work and focus on what we can do to strengthen some of those practice ready skills, clinical judgment, and what that looks like. And if we haven't met, my name is Keith, and I just want you to know that, I pursued my passion to teach nursing after 25 years of bedside practice, primarily in the ER and ICU. But for those of you that don't know me, I just will highlight that I experienced the academic practice gap in real time over 15 years ago. And unfortunately, that gap, that disconnect of, again, NANDA and 3-part precisely worded care plans and page after page of clinical content. I don't know if I'm preaching to the choir or if anybody's experiencing that currently, but there are solutions and there are strategies that all of us can do to make a difference. And that's kind of why I started Keith RN back in 2012, and just creating practical resources and tools to help educators just practically be prepared to teach more effectively, how we can better prepare our students for practice. Because unfortunately, the NCLEX culture still prevails and dominates in nursing education. And there's nothing wrong with preparing for NCLEX. But there is a difference between NCLEX success and practice readiness. And so we want to make it our passionate pursuit as nurse educators that we really put first things first. We put practice readiness. We want to prepare our students primarily for real world practice. I know that's in our heart, but the culture works against us in many programs. And so we're going to talk about how we can change that culture and really keep it easy on us as educators, make it less difficult to teach, because when you teach less, your students acquire a deeper knowledge and learning of what is most important. And I also just want to let you know, just before we get started, that I'm going to be sharing with you how you can access a short breakout session that we're going to be running tomorrow on Friday and Tuesday. It's about a 45-minute Keith RN breakout session on how to practically save hours of prep time every month and introduce your stools to time-saving resources that will simplify your life as an educator. So stay tuned. And more importantly, I want to welcome everybody who's in the chat. So I just want to say welcome, and please, it's a pleasure to come at you and just know where people are coming from. And so Rachael, who is our guest, is an educator in Pennsylvania, but I'd love to know your name, first name, and just pop your where you're coming at us tonight in the chat. And it is a pleasure to have a lot of educators with us tonight, and excited to have this time together. I will just share real briefly that if you're going to Odin next Thursday and Friday in Nashville, Tennessee, Keith and Maria will be there with Keith RN as vendors. And so I'd love to meet you, love to connect. So please, if you're going to Odin, please look us up and say hello. I also want to just kind of give a shout out to the Educating Nurses Radical Transformation Conference that will be in Las Vegas in January, about less than 2 months away, January 15th and 16th. There's the link. That is one conference that if you get to one conference this year, if you want to see Dr. Patricia Benner, Dr. Chris Tanner, the author of Tanner's Clinical Judgment Model, she'll be there, and others. And so this is really their first year was last year, and it was a wonderful conference that really emphasized practice, readiness, practical strategies to develop clinical judgment that align with Tanner's Clinical Judgment Model, which, as we know, is a practice-informed model of clinical judgment. And so it's a pleasure to have Brittany will be there at Odin. So Brittany, I want you to say hello, and anyone else who is going to be coming at us from at Odin. But without further ado, I just want to say thank you again for joining us, taking time out of your busy schedule, and we're going to make this relevant and meaningful for your learning. This has been recorded, and so there will be a link available. And for those of you that signed in, I think that we'll be able to connect you with that and give you that information. So share this with your colleagues if you find value in it, which I'm sure you will. And so without further ado, I want to introduce our guest. I've talked enough. Rachael Lattanzio. She is a kindred spirit. And so I had the pleasure of meeting Rachael a year ago at Odin, I do believe. Was it not the Odin?
It was the NLN conference.
Keith. Okay, it was NLN. They all blend together after a while, Rachael. Yeah, but yeah, it was at the NLN. So that was just before Odin in October. And it was a pleasure to meet you. You've used some of our resources and have had success, and just your passion to be the needed change. I mean, when I look back at that's what I love going to conferences. It's like, I'm not alone. You know, there's other educators who I wouldn't say they haven't drunk the Kool-Aid, but we recognize the need that the NCLEX, there's more. There's more, and we know that deep down, and we just don't know what to do sometimes. How do we teach differently? And I think that's just been my passion, and I can't do a thing without other educators. So it's a pleasure. And I just want to say thank you, Rachael, because, you know, best practices if we don't change the way we teach, and educators like yourself aren't part of that change, nothing changes.
100%. Yeah.
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 I just want to say, in fact, you know what? Instead of me rambling, I want you to introduce yourself. I want you to give educators, just let them know who you are, and just your journey. But I just want this to be about, I want to, make this about you and the things that you have done using best practices that, again, if we use best practices, we're on solid ground, are we not, Rachael? There's a lot of, there's always these little trendy things to do, this thing, and some of it's not always best practices.
Yeah, that's the truth.
And so we don't always have research to even support much of what we do. We'll talk about that a little bit later. But anyways, go ahead, Rachael.
Well, thank you so much for having me. I'm super excited to have this conversation with you tonight. And it's really kind of a full circle moment for me, because I got my doctorate thinking I was going to be a CNO or CEO of some big hospital system someday. And I'm not saying that's still not going to happen. Who knows? You just never know.
You're young, Rachael. I've got the gray beard. I don't see any gray hairs. You're good.
They're there. Trust me. It's dark enough in my office. But regardless, I'd got my doctorate specifically for that purpose. Clinical practice. I really wanted to change the way that we're doing things as a healthcare system in the United States. And then I had the opportunity to be an adjunct for amazing York College nursing students. And it was I don't want to throw God into it already, but it was definitely one of those moments where I felt a calling.
Yes.
And I'll tell you, one of the biggest moments for me, my very first semester teaching, was realizing that the clinical paperwork that we use today is almost identical to what we did 16 years ago when I was an undergraduate nursing student. So think about that for a second. The same way, right? It's the same stuff. And so we're preparing the students for a healthcare system that's transformed completely. And we're handing them the same tools that we used 2 decades ago. So healthcare has evolved, technology has evolved,
Yes.
documentation has evolved, patient complexity has certainly evolved, but clinical paperwork hasn't. And I would notice that students who were really good at filling out clinical paperwork were not always the ones that were getting, really good at like the clinical judgment, critical thinking, patient care side of it. And yet the opposite was often true, where I would see students who maybe were not excelling with their clinical paperwork, but they were excelling at the bedside.
Yes.
And so I saw this disconnect and I thought there's got to be a better way. Why is it that this is what we're using to really judge the students on whether or not they have clinical judgment? And so that is where I started to Google a bunch of stuff like, okay, here I am, this new novice adjunct clinical faculty, and I want to figure out how to teach the nursing students better.
Mm-hmm.
And your name came up, Keith RN, believe it or not, right?
That was many years ago.
It was so many years ago. And it was one of the very first things I saw was this write up on oral care plans. And I thought, wow, that would be awesome. Okay, so let me look into this. And I started to look into a lot of the different resources that you had. And I thought, this guy, he's like onto something and he gets it. And I feel like, in that moment where you feel kind of alone, like, am I the only one who's thinking we need to change this? It felt so validating to be able to have somebody else out there who felt the same way. And so I felt validated in knowing that I'm not alone in thinking this has to change. We got to do better.
No, and
so tonight,
yes, ma'am.
Tonight, I want to challenge the biggest myth that we have in nursing education, which is that our students aren't ready. Okay, I don't believe that. I think that they're ready, but that we're not teaching them the way that practice demands.
Yeah. Yes, we're not teaching. This is the thing that I've observed, Rachel, is that we're not teaching the way that nursing is actually practiced. Now, that may sound kind of harsh, but when you look at our pedagogies and our strategies, when you look at, for example, why are we still a slave to NANDA and a 3-part precisely worded diagnostic statement for our page after page of care planning, when as a nurse, because I went into nursing education after 25 years of expert practice, I mean, in the high stakes areas. And it's like, I didn't think like this. NANDA, a 3-part statement with that evidence by, manifested by, etc. It's like there's a more nuanced way that we think in practice, and it's called clinical reasoning. And there's a framework called Tanner's clinical judgment model that was birthed from practice, that came out of almost 200 articles that Chris Tanner synthesized and came up with those 4 themes that are practice informed. And so when I look at, even this, the NCLEX culture, Rachel, it's like we have this dynamic where we are teaching students a measurement model clinical judgment framework and using the language of recognizing cues, prioritize hypotheses with our students in their clinical paperwork. I've seen it. Right. It's happening.
Yeah.
And it's like, well, that's a measurement model framework that practice doesn't use that language. And Rachel, did you ever use the words hypotheses and cues? No. And so we need to really step back and recognize how deep the NCLEX matrix is in nursing education. And more importantly, begin to look at ways of how can I just basically just teach better? teach differently using best practices and really operationalizing Tanner's model in some very practical ways. And, if you have any other thoughts or comments, the floor is yours.
Yeah, I mean, I have a lot of thoughts and comments on all of this. We're going to get into a lot of it too, and I'm really excited about that. But I mean, I could write a book on all of this. Maybe one day we will together, Keith. But clinical judgment is dynamic, and traditional paperwork and the way that we're teaching nursing students now is static. And the mismatch is why the students struggle, right? It's this mismatch of the questioning and the problem solving and those cues that you talk about. They need to understand them and know what to see, right? But writing a nursing diagnoses and a statement and those things people now even can do through ChatGPT. So what are we going to start doing to see the doing and not the reasoning on paperwork? We're missing it. There's a gap and we need to fix it.
Yes. And that's kind of what I've been about for the last 13 years, Rachel. And again, we got to do this together. This is not a Keith RN project, but it's something that we all need to link arms together. I guess what I'm blessed to do is just create the resources and the tools to help educators. And again, the strategies and the oral care plan article, I found it. I quick searched for it on my blog articles. It was written a few years ago by Beth Corner, who was the one who innovated that. I met her at a conference in Michigan, Mid-Michigan College. I'll call them out. Thank you, Beth, for your work. And I also got a comment from somebody who I don't know if you recognize, Erin Allwine.
Oh, yes. Oh, I love my students so much. I was really hoping I'd get some, students to show up because they're the ones who are driving all of this for me. I mean, they're the reason I'm here. I want to see nursing education change because I'm so passionate about my students. And so, hi, Erin.
Amen. No, that's awesome, Rachel. And it's obvious that I bet you're one of those educators that is difficult, but yet they thank you after they graduate and they recognize that you were the one that prepared them for practice. And that's really our passion because, it's like we want to be liked. Do we not want to be liked? But we can't let that be the motivator of just being soft or being, we've got to find that balance. And that's another topic. I don't want to go down that rabbit hole. But I also just want to share that oral care plan article because that's another innovative educator. And I had Beth as a guest a couple of years ago. And so this is so much fun to have other people and sharing their stories. So is there anything you'd also like to share about any challenges, Rachel, as a new clinical educator? And then we're going to get into this clinical judgment care plan and operationalize kind of like what it is. And you can have a care plan in 2 pages. That's the exciting part. So we're not going to give away too much, but I want to know, are there other challenges that you experienced as a new educator and maybe even still experienced that are kind of those splinters in your brain?
Yeah. So the biggest challenge early on was realizing that content alone doesn't create confidence, right? I think we all see that. So students can memorize facts all day.
Yep.
But clinical judgment and prioritization and thinking through complexity, that's totally different. Totally different. And as a clinical educator, I mean, that's really important to be able to see the difference between that. So the ongoing giants are students overwhelmed with tasks instead of actually thinking, traditional paperwork that doesn't support reasoning, the academic practice gap that leaves new grads feeling totally unprepared. We never learned how to document. We didn't know how, those types of things I hear all the time. Getting students to move from checking boxes to like really questioning and problem solving, prioritizing what's happening with their patients. And here's something else, and some people might not agree with me on this, but nursing education, I think, has fallen into this assumption trap where we assume maybe that clinical paperwork strengthens the thinking, when in reality, most of it just documents the thinking that's already taken place, not the thinking that's currently happening, right? And so in order to really change that, we need to be fluid, right? Just like I said, that clinical judgment is dynamic. So we need to find a way to be able to see the thinking and not on paper, but in the way that the students are responding and how they're acting.
And, and we talked about last month, Rachel, is with the Busywork piece. And it's like almost there's this unspoken assumption, the more paperwork, the better.
Yeah.
And I think that, and then we see literally in some programs where I've spoken at conferences, it is not only just 10 pages, it is 20 pages. And the world record is 44 pages of clinical paperwork every week. Now, I don't know about you, but, that's busy work because we're not, again, one of the things that we must embrace, if there's one thing that another paradigm shift, we must teach less to have a deeper knowledge and to learn more. To get a deeper learning, we have to teach less so we get a deep knowledge of what's most important, Rachel. Yeah. And what's most important is clinical reasoning skills.
Right.
And we don't have to, again, overthink it. We just need to look, how does a nurse think and practice? And again, using a practice-informed framework of clinical judgment, because the NGN aligns with Tanner's framework. We don't have to put the NGN as if that's our magnum opus on a pedestal. It's like, no, just put it in a corner and teach Tanner's. Right. And teach practice, because practice is using Tanner's. Right. They're using Lasseter's rubric to evaluate those reasoning skills of new grads. And so Lasseter's clinic, rubric and Tanner's that aligns with Lasseter, that's the language of practice. And that's what our practice partners are using. And so really using the NGN in any way outside of creating tests for our students for NCLEX should be anathema.
Right.
We should really just we got to stop that right now. And I know that some educators will say, boy, we have just swallowed the hook but let's spit it out. Let's spit out the hook, Rachel. We control our destiny as educators in our programs. And if we're a leader, especially, and I'm curious, has it been a challenge to bring some of that, I don't want to go, whatever you're comfortable sharing, but when you look at the culture in general, let's just talk general. What do you see that maybe I don't see or see differently?
In general, I do. I think it's hard, right? Because how do you as an educator, when you have a number of students, right? So say you have 8 students on the floor, how can you go around and really assess in all of them that they're understanding and starting to really grasp clinical judgment and critically think? And so the only way to really do that sometimes, I think that people believe, is to see it in the documentation that they do for their care plans and their clinical paperwork, right?
And many times, Rachel, they're doing that the next day, that they are filling out things that they didn't even do.
Or they're doing it that day, right? And they're sitting at the desk at the computers and trying to find all the information they can on their patients because they got to complete their paperwork in all its entirety. And if they don't complete it, they're going to be in really big trouble. So rather than going in and doing patient care and actually engaging in what nurses are doing and should be doing, they're trying to find all of the stuff that they need to find in the, computer system so that they can finish their paperwork. And when a student spends hours rewriting lab values or reorganizing information that they already know, that is not clinical reasoning. That is clerical work. That is students who are feeling stressed out about just filling in all the paperwork. They're not actually putting it into practice. And we want to see them put it into practice. Right. So, that to me is that's what we're talking about here. That's the big thing here.
And I've got some, what I want to encourage, and I want to just do a call out to our audience who is watching live, because they get the blessing of asking questions and getting them answered. So Jane Bagley, a colleague at St. Cloud State, once upon a time, I hope she still remembers me, has this question that she'd like to know. I'd like your thoughts on it, Rachel.
Are concept maps still worth using for clinical prep, et cetera, in addition? So, yes, I think they have a place. I've heard students specifically, and I always ask students, and I'm hoping I've got some students on here who can give their perspectives too, how they feel concept maps help. I think that there's a place for concept maps. And I think it's in the beginning, right? So like fundamentals courses, MedSurg 1, I at York College, it's a bachelor's degree program, so it's a 4-year program. And so scaffolding the clinical paperwork to like start where, maybe you are doing some of that concept mapping and more intense type of paperwork, so you're kind of like forced to kind of put it together because you don't really know what you don't know yet at that point. But once you get up to like the junior level where I'm at, which is MedSurg 2, their junior level second semester, they're going to go into their senior level, right after me. Concept maps, I don't know if they're as important anymore. I might have some students who disagree with that and feel like, they do like to put concept maps together. But what I want to see is the doing. I want to see students doing things. I want to hear them talking it out loud. I want to hear them giving report. And I don't want to see it on paper anymore.
Yeah. And what I would say, and I just add to that, Rachel, I do agree. And I would say that, Jane, it's a great question. And I think it's just a reflection that, there's not I think that sometimes I think that like there's one way that magic silver bullet that will develop clinical judgment. And I think, Jane, what I've seen in my own journey and experience and observation is that there's multiple, just like we have multiple active learning strategies, we also have numerous active learning tools in clinical, and concept mappings help as a visual map of connecting pathophysiology and the problem and the lab values and the assessment data. Does a beautiful job. I mean, I think the strengths of concept mapping is it really helps students connect the knowledge of pathophysiology to practice and seeing how the problem is this and now their labs are this. Why are they that way? Oh, their assessment, they can see how it's all coming together. So I think that's the strength of concept mapping, but we also need to build on that with the clinical judgment skills. And so, I would like you, Rachel, to kind of like, do you want to transition and just kind of dig into the actual clinical judgment care plan?
Yeah, let's start talking about it.
That. Because again, the article that we're basing this on, and again, I want to just do a shout out to the original author who had that inspired this tool is Nancy Eisenman. And for those of you that might be late in the chat here, I want you to put this, you can download this on your CENP database. So be sure to grab it. Inspiration. She just talks about how you can use, if we're going to do a concept map, Rachel, she uses, a clinical judgment concept map. And what I kind of did with this tool, just to kind of help you understand, is that I said, I've been a passionate fan and advocate of Chris Tanner's clinical judgment model for 13 years. I was doing Tanner in my case studies and my other resources before it was cool, or before educators heard of even Chris Tanner. She was kind of like beneath the radar in a lot of circles until the NGN and the NCSBN adopted and modified her framework. But what I saw with this concept map, I love the blending of a concept map that is kind of linear. It's not a visual with squares and circles, and you think of a traditional concept map, but it's linear, but it takes, the steps of Tanner's noticing and then deconstructing it and breaking it down, kind of like Lassiter's clinical or judgment rubric does for simulation, but do it in a very practical way that helps students basically reason using Tanner's framework as they're collecting their clinical data. So it's like we're using Tanner's and developing these noticing skills and interpreting skills just like a nurse does in practice. And so it's like aligning clinical judgment, a 2-page care plan, and I just took my own lens and I made it my own. So I just kind of, I looked at what Nancy had kind of come, and I made it my own. And so I really just kind of took Tanner's and I blew it up and I expanded it and created a tool that is found in our Think Like a Nurse membership in our clinical judgment course. And so, that the principles though of Tanner and and I'll show you the picture of the tool, Rachel, and you can kind of explain it. But why don't you just kind of like, I'll just, would you like me just to put page 1 on the screen and for you to just kind of, what would you like to do it? How do you want to do it?
Let me set it up. I know everybody's super probably excited.
You got to set it up. Okay.
But so just to give some context to this, right? First of all, I'm not against clinical paperwork. I'm not against it in its entirety. I'm not. But I am against paperwork that doesn't build thinking. And we owe it to our students really to replace that static assignment with dynamic frameworks that actually strengthen clinical judgment. And so I recognized very quickly on when I was doing clinicals that the traditional multi-page care plans were not developing the skills that our students actually needed at the bedside. And they were spending hours sitting at the computers during their clinical time, trying to fill out all of their clinical paperwork. And they were not doing the thinking and the nursing that we want them to do. And so I went to the drawing board and started trying to find some research on it, because I'm thinking, like, there's got to be all this research on clinical paperwork, right? If we've been doing it this way for so long, then it's got to be in, there's got to be sound research on it. And no, there's not. And so there's almost no research. I mean, literally a handful of studies examining whether traditional clinical paperwork improves clinical judgment, clinical reasoning, or patient outcomes, you name it, right? So we assume that it works better because it's what we've always done. But familiarity is not evidence. And I wanted to be able to provide some evidence. And so I was motivated to pilot the clinical judgment care plan. I saw your clinical judgment care plan and I thought, this is perfect. I mean, it's short, it's sweet, it's not prescriptive, and this would be so much better for my students. But I needed to be able to prove that, right? I wanted to be able to actually do some research on it and see, okay, like, let's compare traditional care plans and paperwork to the clinical judgment care plan paperwork that you have.
Right.
And so in looking at yours, it fit all my boxes, right? It hit every single one of them that I wanted to hit. I wanted it to align with the AACN essentials, operationalized in Tanner's clinical judgment model, mirror what nurses actually do in practice, so it actually makes sense, and gives students the autonomy to actually think. And so your tool checked every box. And so this is maybe where you can show everybody now what I'm talking about.
All right. Let me share a couple things here before we jump in, Rachel. Number one, I'm going to share an article that's, it's not the exact one that I think you're talking about, but we have an article published, I do believe about 3 years ago, titled Traditional Clinical Outcomes in Pre-Licensure Nursing at an Empty Systematic Review, where basically they found out that the ways that we're teaching the apprenticeship model of clinical education of one faculty and 8 to 10 students, we have no evidence to support that as being efficacious, efficacious. And so it's like, we've got to recognize that, we're a newer profession. Let's get the research. Let's do good research. So I love your emphasis, Rachel, of saying, hey, if I'm going to do it differently, I want evidence to support this, or at least show that this is a better way and a different way of doing that. And so I just, wanted to share that. And I also just want to quick mention that, we're going to be doing something with Keith RN a little bit differently that we've never done before, actually, quite this way. Tomorrow and on Tuesday of next week, we're going to basically just offer a free breakout session, less than an hour, 45 minutes. We're going to talk about strategies and tools and some of the resources that are available to educators, and so on how you can connect that classroom and clinical learning, and again, practice the thinking of practice. That's our goal, and our clinicals and our classrooms need to kind of intersect and come together. And again, they're in silos still, and so it's been my passion to create some solutions. And I just want educators to know that if you want to learn more about Keith RN and some of the ways that we develop clinical judgment with our resources, the clinical judgment care plan is just one of dozens. So let's dig into this one, Rachel, and let's have some fun. Okay. Mm-hmm. So what I'm going to do, I'm just going to pop this on the screen. I'm going to basically kind of just share with you just what this tool is, and just let me pull it up here. And it's going to block out our faces here for just a moment, Rachel. But what I want you to do with this is kind of just In fact, that's the wrong one. That's steps 3 and 4. So again, Tanner's clinical judgment model. And again, if those of you that aren't familiar with it, I'm going to pop it on the screen quick, because Tanner's aligns with the nursing process that aligns with the NGN model. This is an infographic that ATI gave me permission to use. You can see the steps of Tanner's: noticing and its alignment, interpreting skills. What does this mean? The analysis and planning of nursing process, and you can see the 3 steps of the NGN model. The responding is the 3rd step, and that's implementation and take action. And finally, reflecting on your thinking as well as on the patient and how they responded to the plan, and you can see its alignment there. And so that's Tanner's framework. It's 4 concise steps. It speaks the language of practice because it came from practice. It was the chicken, Rachel, not the egg.
Mm-hmm.
The NGN model is the egg. So let's start with the chicken, and let's go into the first page of this model and just really looking at how it just takes the first 2 steps of noticing and interpreting. And we always start with noticing, so we don't go any further. We just start with that first section. And just tell me, your students, how do you use it, Rachel, in your clinical? So just give us a window to your world, please.
Yeah. So first and foremost, you notice about this that it's clean, it's concise, it's intuitive. It isn't 8 or 44 pages of paragraphs. It's structured around that, clinical.
That's the second page, and that's the first page. Yep.
Yeah. So the traditional plan tells students what to write. And this tool, because it's really more a tool in my mind, it teaches students how to think. Right. And it gives them, I had a student, Caitlin, who I hope is on even, because her statement to me was so profound this semester. She said this clinical paperwork gave her the autonomy to think, and the autonomy to think. So the paperwork that we're giving them that's so prescriptive, we're taking that autonomy away from the nursing students to actually think on their own about what they think is important. And then it gives the professors and the instructors, the clinical instructors, the ability to look to see, okay, this is what the student thought was important in noticing, in interpreting. This is how they prioritized. It's not only so much better for clinical faculty to look at and see, but it makes so much more sense for the students too. And it gives them the ability to really think on their own, which is what's so special about it.
And so would you like to look at the first page and just kind of put that together?
Yeah, show them the first page.
All right, let me pull that up here. And so let's and just kind of just start from the beginning and just kind of break that down, Rachel, and just kind of how you're, just basically how that was used in your clinical.
Mm-hmm. Yeah. So noticing what is most important, that assessment, right? And this is kind of like the past medical history, the assessment findings, the vital signs, the lab, the diagnostics that are important. It's not telling them what to put. It's the students are thinking to themselves, okay, so what out of the assessment is the most important about this patient, right? What do I need to put here? What pertain, what they were admitted for what exactly is past medical history puts them at risk for why they're here and their assessment data. And then the interpreting what data means by understanding the pathophysiology of the problem. This is where they're defining in their own words. Now they're actually putting it into their own words. They're defining those problems and then thinking about, okay, what could make it worse? And so interestingly enough, Keith, 3 years ago, you posted a video on YouTube about the 3 C's of clinical judgment, like caring, critical thinking, and clinical reasoning. I don't know if you remember that. And the NIH and the American Journal of Medicine have even referred to the 3 C's, and they talk about it in clinical competence, right? They talk about caring, communication, and competence. And so I'm going to take it a step further and talk about the 3 C's as in clinical judgment, cues, connection, and choice. So if we think about cues, right, we're thinking about the student having to understand, to learn, to see things accurately. Connection is that student making the right meaning of it all. And then the choice is how are they going to react? What are they going to do? So what cues really mean? Cues are the raw data. So that first page, that you showed, the vital signs, the pain reports, the skin changes, the breathing patterns, the lab values, mental status, things that are nonverbal. The something feels off, right? So that's where they can put it in their own words, like something feels off about this patient. I want to talk about that a little bit later too, about the intuition that we really need to build in these nursing students that I think is a big part of the clinical judgment. But, cues are the spark of clinical judgment. And if a student doesn't see accurately, then they can't think accurately. Right. So a student sees new confusion, but documents the patient's resting comfortably, or the blood pressure drops to 95/56, but focuses on the pain score instead because the pain is 10 out of 10. Notices increased work of breathing, but then, doesn't recognize that it's actually impending, deterioration, and the patient's going to end up coding. So students rise to the level of the cues that they notice. Right. And if we give them the ability to notice on their own and not just fill in the blanks,
right,
then we're turning that into clinical judgment. And then the connection side of it is turning those cues into the priorities, right? So this is where we're going into the interpreting and then to the second page.
Okay, and let's look at the interpreting, because I really, one of the things that I did when I developed this tool is that I really kind of, what I did, Rachel, in essence, I looked at my case studies and how they basically align also with Tanner's model and kind of really made intent. I have my hobby horses, like you got to understand pathophysiology, and you've got to understand like there are certain things that are red flags. Like it's not just like, we have to teach our students a combination of like, what are you noticing that's most important, but also a red flag of a elevated temperature, elevated heart rate for an adult. It's like, that's, literally we have to have our students literally should be memorizing the Muse scale, those medical early warning tools that tell us that, if they have one or two of these red flags, that is like a blinking, and students oftentimes they'll notice a 110 heart rate, but they'll think nothing of it because they don't know what it means.
Right. And that's a good point. Yeah.
And so let's look at the interpreting, because and you're absolutely right, Rachel. What I did with this tool is that just how my case studies have, assessment data that has an open-ended question. Because when I wrote my cases, I said, nurses never think in multiple choice.
No.
And how are we evaluating clinical judgment, Rachel? Even the NCLEX is a multiple choice exam. Those are just more complex multiple choice items. So a 3-column matrix, select all that, apply, bow tie, they're nice. They do deepen the thinking, but there's still multiple choice. And if you can even say multiple guess at time. And as a nurse, you don't have that option in practice. You either know it or you don't. And so that's why I made the care plan not prescriptive, not giving it too much guidance, saying, what are you noticing with that assessment, vital signs, labs, etc., just like you do in practice. And the cases that I've written help to practice that even in your classroom. So let's look at the interpreting, because that really has 4 different categories. So why don't you just go over those for us?
Yeah, so defining the current problem in their own words. And then how can the problem get worse? So that's predicting those possible complications, the relevant comorbidities, the things that are going to impact, right, that thing that could get worse, and defining that current problem. And then the psychosocial, which I absolutely love because I don't think we ever focus enough on psychosocial. But really, that's the hardest part. My students will say, that is the hardest part for them, that interpreting right there. And that's where that connection and that judgment is, because students will think, right, that the challenge initially is in gathering all this information and doing, this paperwork, the prescriptive type of paperwork. And then I give them this and they're so excited because it's 2 pages and wow, there's not a lot on here. And this is so cool. And it gives me the ability to think on my own and do my own things. And then the very first time that they use it, they're like, I don't know what to put here. What should I be putting here? And the challenge, right, that they find out is not in gathering the information, but in making meaning of it. And so
Yes.
Connecting those things, like connecting tachycardia and low blood pressure and dizziness to early shock.
Like a concept map does. This is like a
Kind
linear,
There
this
you
is still
go.
a concept map. It's
But
just not.
writing it out, right? And they're like they're conceptualizing it in a different way. They're not doing, blocking it. It becomes one fluid thing. New agitation and hypoxia and fever, maybe sepsis, maybe a pain out of 8 out of 10 and a heart rate of 112. We've got some unmanaged pain going on. What's happening? Post-op and low urine output, these types of things, they're the connections. And connections in clinical thinking, it's always a scattered puzzle of pieces, and you have to be able to recognize the picture before it's fully formed. And so I think this interpreting really gives them the ability to look at the data and figure out, okay, well, what does this mean for my patient? Because it can always mean different things depending on the patients, right? And so that's, yeah.
One of the things, Rachel, that I'm very passionate about, because as a rapid response nurse, in the last 15 years of my practice, I worked in the critical care float pool and circulated to that role. And, the problem is that, there are rapid responses that didn't have to happen. And there are codes that don't have to happen if a nurse anticipates. And this question right here, Rachel, number 2 here. So when you look at saying, okay, their current problem, let's say that it's, that they are having, is heart failure with difficulty breathing. But how could that problem worsen? So they have the present problem, but again, we need to recognize that every patient has risks. And what are those risks that they can develop that can lead to a potentially life-threatening complication that they don't even have yet? So it's kind of like they have this current problem, but let's anticipate the potential problem that could develop as any patient they could go into respiratory distress or failure. What does that look like? How do you know it's coming? And then respond appropriately when you see those early signs and symptoms. So I really wanted to embed problem recognition and having our students, that as educators in the clinical setting, we must be asking our students not only what is the current nurse, problem or medical or nursing priority, but how could that worsen? What is the problem that could develop because they're here for like a post-op? They could go septic. What does that look like? Et cetera. So yeah, I just wanted to make that problem recognition piece visible and for students so that they can begin to think vigilantly. And again, even if you look at the NGN case studies that we're all kind of aware of, and that whole, in a lot of our resources, they always focus on the current problem. Like, okay, here's your data. What's the current problem? They never dig deeper than that. They don't ask what are some potential complications. It's always what's the present. Now that's a good thing for a beginning nurse, but we got to prepare them for real world. We want them to develop that type of problem informed thinking. And that was my passion. And that's where I really made it my own and really talked about and made that part of interpreting, that we're anticipating and looking at that. So anyways, let's go to page 2. Let's go to the next 2 steps of tennis. So we have the noticing. We now interpret and integrate pathophysiology and problem recognition, current problem, holistic care. We've got to care like a nurse, Rachel, to think like a nurse. That's Chris Tanner, by the way, said that, not me, in her article on thinking like a nurse. That is something. I don't have the link for it, but I'll see if I can dig it up. In the meantime, we're going to go to page 2. Mm-hmm. Let's talk about responding. Yeah. And so let's look at a care plan, Rachel. We can do a nursing care plan in 4 simple steps. Do you believe that? Or what did your students, was this dumbing it down, or was this relevant and meaningful when it comes to actual responding and the care plan itself?
Yeah, my students love this. They love it. Every single student I've talked to who's used it, you need a little guidance initially at first, right? Because when you've had such prescriptive care plans all through nursing school, to go to something like this does require you to think more and to think like a nurse. So it's not always easy, right? It might look like it's shorter, there's not as much to it, but it requires the students to really put down their thoughts and to know it, right? And so the second page, responding and the evaluation, this is the choice page, as I call it. And this is the action step, the behavior. It's the intervention, the communication, the escalation, the evaluation. And so now they're asking themselves, okay, so now that I understand what's happening, what should I do? Who do I call? What's the safest, most urgent intervention? How will I know if it worked? What would happen if I do nothing? These are all the questions that start to come out of this responding and the evaluation. And so understanding the nursing priorities and priority interventions, what outcomes are you going to want to see? These are all things that we work really hard on all semester to really hone in on. It takes a while. It's hard. Nursing priorities are not always easy, and priority interventions are not always easy. And I'll say, depending on what kind of floor you're on, your priorities can change and fluctuate multiple times throughout the day. So, when you have students who have, 4 or more patients, it becomes a lot. So that to me, though, is the choice. And that's the doing. That's the seeing what they're doing, how they're actually putting it all together, and now deciding how they're going to run with that information.
Right. And what's really powerful, I think what we need to remember, Rachel, is that when we're teaching clinical judgment, what we are really developing are clinical reasoning skills or competencies to get to the judgment, which is the outcome. So when you look at each of these steps of noticing broken down, those are all specific skills of clinical reasoning. That is that thinking in action, that when you put it all together, those noticing sub-skills, the interpreting skills of the problem, the possible problems, and and the holistic implications. Now you're into responding with now the outcomes and the priority, the interventions, the expected outcomes. That's an NCLEX question. How many of you know that on those 3-column matrices they love? Is this expected or unexpected outcome? You see, so the NGN is doing a good job measuring the responding of a skill of that particular, of that reality. But when you have it as an open-ended question as part of your care plan, that's making your students think, not just prescriptive and check a box.
Right. Yeah.
And so, let's go into we just have several minutes here. This time has gone way too quickly, Rachel.
I know.
We're going to finish it. We're going to go through it. And the bottom line is that, there's your response. So there's your care plan, Rachel. And did your students find that challenging? Or I'm just kind of curious because it's, this is only a two-page clinical reasoning care plan. And that specific section is really, that's what I have in my case studies, are always that exact same section. So I just kind of replicated how I use that in my case studies to practice. But again, your students didn't find it, it was simple, but it was hard. I mean, what were their comments?
It was challenging in a welcoming and exciting way, right? It made them think differently than they'd thought before. And they were having to pull from, their own words and figure out, well, what is important? I don't have, this prescriptive paperwork that's telling me exactly what I should be writing here. It's so much more open-ended. And again, giving them that autonomy to really think through it. It's not easy at first. They really struggle with that. What do I put? What is important? But then it starts to click.
But that's coaching that you want to have, because really, as clinical educators, especially, we want to have that Socratic dialogue. So it's not just like the students just fill it out and they're done. It's like we want to be engaging with them in our clinical for just minutes at a time, 2 or 3 minutes here, 2 or 3 minutes here. But we are continuing a Socratic dialogue of clinical reasoning that's going to get their wheels spinning. They need to come up with it. And we practice that repeatedly, and those skills of clinical reasoning. And again, we can get to that baseline clinical judgment competency that our students must possess that most do not currently. So
it's not about giving them the right answers. It's about giving them the right question. And that's why systematic questioning is so important. And that's what I do the entire day of clinical. I walk around and I ask them, okay, so what do you think the nursing priority here is? What's the biggest problem with your patient? What's the worst case scenario? I talk through the care plan, right? So I'm actually talking through it with them. But the Tanner's model mirrors how clinical intuition forms. And intuition isn't magic, right? But it is a trained pattern of recognition. And when students learn to notice and interpret and respond, they start developing that gut level clinical instinct that is going to take them through long after graduation. And that is so important to start building that in them now and not wait until they graduate.
Yeah, absolutely, Rachel. I also want to get to the reflection piece because, as you know, what Tanner's clinical judgment model does that the NGN model does not do and will never do is emphasize the importance of nurse reflection. So again, the final step of the NGN model is evaluation. Same thing with nursing process. But, Tanner's says that you not only have to evaluate the patient response and has that patient improved, no change or declined, and that is a 3-column matrix that we're practicing as well. It's also very practice-informed thinking, but is this looking at the student's reflection, looking at, did you, what was some of the, when you look at your thinking, did you basically, did the patient status and change? Did it improve? Were there additional interventions, expected outcome? And so reflecting on how that patient did, just kind of curious how your students found that section, Rachel, and just anything just in general with that whole putting this all together.
Yeah. They love that part too. We talk a lot about that kind of thing in post-conference. So a lot of themes will come up when we're actually talking through it, which is really nice. And what I love about that care plan itself, because it gives the students the chance to really talk through things as well. And I think that's important. But one of the reasons that the Keith RN clinical judgment tool works so well is because it doesn't hand the students a script, right? It hands them a framework, and the students still have to think. They still have to connect those cues, and they have to articulate their own understanding. And so, sometimes they get to that bottom piece and they're like, wow, okay, I realized that those interventions that I did didn't really work. And so I guess I have to go back to square one and figure out what we need to do to better this patient. Sometimes that's in your hands and sometimes it's not. But allowing them to have the autonomy to go, okay, well, what am I going to do next? How do I do this? It's beautiful.
Well, Rachel, we have just a few minutes left, and I want to close with some questions. I also want to just, I don't know, there's a lot of love out there for you. I don't know if you know who Rebecca is, but she also just kind of affirms as a student that this care plan helped her so much and strength, and I want to know, Rachel, you know what? I'm just like a mad scientist. Sometimes I feel like in my Keith RN home office, in my basement office, and I'm just kind of in a little bit of a silo. I want you to know that this really this touches me because I don't always realize, I create resources, and yes, it's, you don't know if it's a hit or a miss or, a flop or a fail. And to see students respond, to see your feedback, to see students' feedback, because again, adult learners are looking for relevance, Rachel. And when they see relevance, they know it's meaningful and they will bend over backwards. They will go to that bar because they know this is really important. Mm-hmm. And I think that's what your students are recognizing and what Rebecca is sharing here, and able to translate her knowledge, not only from clinical, but also, I love this, that it also improved her exam scores because she's thinking more like a nurse.
Yeah.
And what we're developing is that repetitive reasoning and a framework. So if we give our students a practice-informed framework and break it down the way a nurse uses that knowledge, Rachel, this is how we prepare our students for practice. And I think I really want every educator to embrace that responsibility and that you can be the needed change by just willing to teach differently. And so there's some questions I want to get to, Rachel. So let's just get to as many as we can here. And, this is one that's kind of, this is always, but looking at evaluation tools for student performance each week, how do you basically, when you look at evaluation, there are some programs that use Lassiter's clinical judgment rubric, which I would encourage you to Google and access that. That's a resource that is used in simulation, also been adapted for clinical evaluation. Do you have anything you'd add to that, Rachel, real quick?
Yeah, Lassiter's is great. And that's also what I used when I did my research. Okay. So I would, again, suggest that. But we have, evaluations that we do midterm with the students and then final. And we base those again off of ASDN standards, essentials. And then, you as the clinical faculty are the expert. So when you're looking at their clinical paperwork and you're doing the Socratic questioning and you're talking them through, what do you think is the priority and what's the problem with this patient and what are you going to do? Like that's the grading there, right? I don't think I've ever seen anybody fail nursing school because they didn't do good on their clinical paperwork.
Right.
So the question really becomes like, to me, we need to see more tools out there that are demonstrating what the nurses do, the nursing students do, and not, we need to change nursing education from assignment completion to cognitive coaching. Right. We need to see the things and not on paper. We need to see them doing it. Yeah. So finding better tools like Keith RN's tools that promote autonomy instead of prescribing their thoughts. Yeah. That's what we need. And, if we're still grading paperwork instead of judgment, we're missing the whole point. We're missing it. So, that's a hard question. What kind of rubrics do you come up with? How exactly do you judge it?
You said, how do you grade it? This was another question I wanted to get to. So, and this is, again, talking about how you grade these, kind of that. Yeah. What are your thoughts in closing?
Clinicals for us, and I don't know how it is elsewhere, but clinicals for us are pass-fail, right? And so there's no real grade that's assigned to the clinical paperwork, which I like because it allows them to not do clinical paperwork perfectly, and you talk them through it and hearing them explain stuff. And again, like I said, I've had students who excel and paperwork is beautiful and you could publish it, but they're not in the patient's rooms who are really doing like this exceptional patient care. And on the other hand, I've had students who have been exceptional nursing students, and I know they're going to make amazing nurses and actually have gone on to make amazing nurses. But their clinical paperwork was not always that great. They focused more on the care. Mm-hmm. And personally, that's what I'd like to see. So as the clinical instructor, I'm walking around, I'm seeing that they're in the patient's rooms. I'm going in and talking to the patients when they don't know that I'm going in and talking to the patients. Hey, how's everything going today with your nursing student? I'm seeing from the nurses, and the nurses are telling me, wow, these nursing students are incredible. They're so helpful and they're asking the right questions. And so that's how I'm grading, if that makes sense.
Okay. If you have any follow-up questions, we'll have just a couple extra minutes here to just kind of wrap that up. But I also just want, in closing, one last comment and anything else that might come in. But I love this when people realize that you may be a unicorn, but there are other unicorns who think a little differently out there. And I think we just want to make this mainstream. I think this is just really when we look at best practices made practical. But again, you're not crazy for realizing that, we don't have to do it this way. That, and again, we don't have to throw out everything, Rachel. We don't want to get into that extreme, but we need to question why we do what we do, and let's create the research. And I think that's something that I want to share in closing, that Rachel and I, you did a study. Some things didn't go the way that there was some limitations, but the bottom line is that we'd love to repeat a study using this care planning tool. And I just wanted to throw an open invitation to anyone that my email address is keith@keithrn.com. And I would love to do a multi-site study with this care planning tool and do some quantitative and qualitative kind of a study at the same time to basically look at this and design a very good study. And if there's anybody with a DNP or a PhD EDD that needs a good study, this is something that we'll hopefully do in the months ahead. Not probably this spring, probably next fall, Rachel. So I want your program to be a part of that. And anybody else, this is an open invitation to a multi-site study, because we really need to get the data to support why we do what we do. And so I just really want to make that a call out in closing. But I also just want to share one last thing, Rachel, and you're going to have the final thought with your takeaway that you want people to get from this presentation. But I also just want to let people know that, if you're intrigued, saying, I don't know a lot about Keith RN, and I'm just kind of like, we kind of have just a very simple session for you that, again, we're going to be doing. I'm going to put a little QR code. If you're not on your phone right now, I'm just going to share just a QR code. That's just an easy registration link. If you just like to check out and just learn more about the clinical judgment care plan and other resources that we offer, because really we really have some unique offerings and other things that are available to educators. And a lot of people, we're still kind of like a boutique Etsy brand, and that's okay. I don't want to be big, but I want to be influential. And I get influenced by educators like Rachael and others being a part of the needed change. And again, you don't have to reinvent the wheel, Rachael, and that's the positive thing here. So, you know, you can just partner together, and it's a pleasure to do that with you and your program. And thank you for all you're doing. In closing, I'm going to see if there's any other last comments here, and then I'm going to give you the final word for your takeaway. There's one thing that you want educators to take away from this topic and what that looks like. Basically there's no other comments. So you have the final word, Rachael. What is your takeaway? So educators who are still here, we've had a lot of participation here. This is a blessed seat. So thank you all who are here and still here. And Rachael, what is that final takeaway that we can just kind of like as an exclamation point? What do you want educators to take away?
Yeah, I mean, that's hard because, again, like I said, I could talk about this all day, but I think the final takeaway would be that if there are educators out there who are feeling stuck in using traditional care plans, you're not alone. I've been blessed to work at your college, and we have really progressive, incredible faculty who we come together and we collaborate and we talk about different ideas, and we're constantly evolving and trying to change those things. So they're open to the idea of us, you know, shifting some stuff with the care plans, which has been great. But start small. You know, join this research study if you'd like to with us. We don't need a revolution. We just need intentional shift, right? We need to be able to kind of come together and realize, like, we need to do something better for our nursing students. And so we're not alone. We're in this together.
No, absolutely. And it's together that we make the difference, Rachael. And so, you know, I just want to, you know, I'm just kind of just blessed to just kind of, you know, there are other leaders out there. I'm just one of many, you know, I mean, you still have some great, but my passion is just creating the best quality tools for educators. So we don't have enough time to bring about needed change. And that's kind of been my passion, is I'll just create the tools and you put them to use and be blessed. So thank you, Rachael, for all you're doing.
Yeah, and I welcome emails and
and you know what? Thank you for sharing that. You know what? I have your, you know, this is let me just pull up the let me just get Rachael. I've got her already here. So if you want to get in touch with Rachael, if you had a question that didn't get answered in this chat, or just something came up afterwards that you just want Rachael, I don't think you know, if you're like me, you are there for educators and you'll 100%. Respond to anybody who emails you, right?
Yes, 100%.
Absolutely. And I will as well. So again, if anyone has anything that I want to send my way, at keith@keithrn.com. But this is Rachael. And Rachael, you've done some great work, innovative work. And I just want to say thank you.
Well, thank you.
Bottom of my heart, because it's such a, you know, this is how we bring about the needed change. And so I'm not going to be around, you know, I've got my gray beard and I won't be around forever, but I know that younger educators are going to carry a torch, and all of us can make that difference for such a time as this. So God bless you and thank you.
You too. Thanks so much, Keith. Thank you for giving us.
Thank you, audience, for coming, and we'll be back next month. Godspeed and have a wonderful rest of the semester. Take care.